So I have nothing to disclose. So here's the patient presents, 64-year-old gentleman presented to the hospital. He's admitted with new onset angina, diabetic, hypertension, hyperlipidemia, lifelong non-smoker. Would mention he has some mental delay, which really kind of compounded whether or not to proceed with anything. Past medical history is remarkable for premature coronary disease. Has taken aspirin, metformin, and torvastatin. Blood pressure normal when he came in. His labs were normal. His EKG was normal when he presented. So here's his diagnostic angiogram. You can see a cranial view here. His LAD has severe proximal disease. He has severe distal circ disease. When you go in the caudal projection, it looks like he's got some ostial circ and distal circ disease as well in his LAO-caudal. I think the left main looks okay, but there's, to me, prox LAD, at least some question of circ disease proximally, and then this distal circ in his right is non-dominant, small, occluded. So this left circ actually supplies blood to most of the inferior wall. So he was seen and evaluated by cardiac surgery, thought to be a poor candidate largely because of his mental delay, although he was a functional person. Decision was made actually by the team taking care of him in the hospital to just optimize his medical therapy and then see how he's doing on medical therapy alone in the clinic. Start on metoprolol and isosorbide, reasonable doses. Prior to discharge, his blood pressure was 90 over 60, heart rate was in the 60s, so he was optimally managed. Prior to follow-up, he was actually seen in the emergency department a couple times with recurrent chest pain, discharged, not admitted to the hospital, but just discharged from the ED to follow up in clinic visit. And then came to clinic. And then ultimately, after a lot of thinking about this, talking to his primary caregiver, we decided to proceed with PCI of his LAD and circumflex artery. So the plan was actually to IVIS the left main circ. You can see, you remember he had questionable disease in the proximal circ and the distal circ. So here's his left main prox circ here. He's got probably a moderate lesion here. Mid vessel looks okay, and then you get down to the distal vessel. We knew angiographically that looks severe. So while we were doing this, the patient had acute onset of chest pain. He was becoming very ill. And so we take our shot here, our initial angiogram after pulling out the IVIS, and you can see he's got essentially his whole circ is filled with clot. His left main has clot in it right here. Here's his initial opening pressure, and then he developed this idioventricular rhythm, dropped his pressure, rapidly deteriorated to VT, then VF, requiring shock. So at this point, now we're trying to figure out what we're going to do with this guy who's in shock just after our diagnostic. So we had called for rapid intubation, performed ACLS, CPR. As I was kind of working the coronaries, my fellow got access on the contralateral femoral side and decided to put in an Impella. We wired both, the circ was already wired, but then wired the LAD, did aspiration thrombectomy of left main LAD and the circ, gave an additional bolus of unfractionated heparin, and the subsequent ACT was 317, and then finally got return of spontaneous circulation after about 10 minutes. And so this is after CPR, everything obviously had come out. So this is our angiogram here. You can see the wires back. We've restored flow in the circ, but now the LAD is occluded. You can see that there's probably still some clot there in the left main. So now we wired the LAD, kind of focused on the LAD. You can see that we formed multiple balloon dilations of the proximal LAD. We had some difficulty getting the aspiration catheter actually down the LAD. This is our angiogram. Pretty confident that our wire was within the LAD. You can see he's got really calcified vessel all the way down. But I really wasn't sure if this was all full of clot, if it was, just the proximal lesion, if we lifted up a plaque or not. So we actually took it over the wire balloon. We had a short wire in, put a syringe on the back end of the balloon, and we kind of hydroplaned the over the wire balloon down into the LAD. And then we pulled the wire out and then injected distally just to make sure where our wire was. And then you can actually see that this backfills all the way to the proximal LAD up to that diag. So then at this point, we're thinking that we're going to just stent pretty much from distal to this diagonal all the way back to the left main, and that this was either a disrupted plaque or some clot or, a combination of both. Due to the fact that we were unable to deliver the aspiration catheter, we exchanged out for a wiggle wire, basically re-advanced this down, and this is a wiggle wire here. We deployed a 2.75 28 millimeter DES, again, a very heavily calcified vessel. You can see the stent is underexpanded here, and then distally as well. We post-dilated with a 315 NC balloon, and then proximally we hit this with the 308, a very short balloon to try to crack the calcium. Then went up to a 358, again, trying to just crack that plaque and expand the stent. So then this is our post-IVIS after doing all that. You can see the stent is well opposed proximally. You get to the mid-vessel, you have very heavily deep calcium. You see the shadow here. And this is the area where we were just going up with a very short balloon focused dilation of that vessel, and then expanded and opposed, had great apposition distally. So this is our final angiogram. And then the LAD, not the best result in the world, but I think at this point we're looking to get out of Dodge. We've got him hemodynamically stable, the impella is still in, and we've got flow. There's probably a little bit of clot here in this proximal LAD, or proximal circle, although we re-IVISed into that and did not see anything. So it's either calcium or clot. Regardless, we weren't going to go after that. So he's transferred to CVICU, and actually I think I failed to mention it. We gave a bolus of integralin at that point, probably voodoo, but I think it made us feel better if there was residual clot. Transferred to the CVICU, weaned off vasopressors in 24 hours. Impella was removed at 24 hours, eventually extubated. EF was 20% or less during the hospitalization. He was discharged on hospital day 10, and then at follow-up his EF had recovered. That's it, and we can maybe move to panel discussion here.
It's a great case, thanks. So any thoughts from the panel, just general topics, like abrupt closure?
Yeah, congratulations on saving that one. So our gut reaction, I think I'm going to speak about for myself. My gut reaction is to be in denial when this happens. And I think you have to resist that and move quickly. And so getting hemodynamic support, I think, is the most critical thing you can do when you see this type of complication, because all of us know that that's going to take forever to treat effectively. And so maintaining circulation is going to be of utmost importance. To touch on the technique you did in the LAD, there's one catheter, there may be others on the market, but the one catheter that I think can allow you to maintain a wire position in a vessel and inject at the same time is the Pronto LP. Aspiration catheter. It has a separate stylet for a separate lumen for the stylet and a separate lumen for the wire. And so you can actually, over your wire position, inject into a vessel to visualize. If you see clot in that scenario, you can then put your aspiration catheter on that same lumen and do it at the same time.
Yeah, sorry.
And so in a situation where you don't want to lose wire position, I think that's a good technique to use.
Yeah, we do that. I think we use the Teramo version of that, and you can do the same thing. We were unfortunately just unable to deliver anything, and that's why, and even despite ballooning, pretty much nothing would go down there. So we left the wire, and we had a short wire and basically just hydroplaned in over the wire balloon, so we never really lost access.
Yeah, that's a great save, really great job. And just to kind of echo on the hemodynamic support, by far the most important thing. And even if they're in sustained, you're doing ACLS, the one thing I will say that's changed probably in the last 2 years in our practice at Ohio State is that as interventionalists, we've become more familiar with ECMO, which we haven't before. It's traditionally all the surgeons would put it in. And we developed a ECPR program, Columbus Fire Department, for out-of-patient cardiac arrest, where we put patients on ECMO in the cath lab. Until we started that program, we all have vascular access skills. We should be able to implement ECMO, but it was a surgical thing at our institution. But I will say that we've had a couple patients, similar situations where we just couldn't get them out of out of ACLS, where we put them on ECMO and they walked out of the hospital. And I think without that, they probably wouldn't have survived. And the second thing to consider, if you are going to do it, is to get an automatic CPR device in your cath lab, so you're not radiating your staff or the fellows. In our case, a lot of times we're doing the CPR, and that's critical too. It gives you good CPR, and it gives you time to get your cannulas in and get perfusion down, and so forth. Just a point.
Yeah, that's a valid point. We had a STEMI maybe 3 weeks ago. Couldn't get him out of VF. It was an inferior STEMI. We couldn't get him out of VF, and we put him on ECMO, and then we were able to stabilize him. So we cannulate in the cath lab as well. So I think once we started doing that, we be able to take care of much sicker patients.
Curiosity from the audience, how many people are cannulating ECMO in the cath lab? So I think that's changing. I think it traditionally was seen as a surgical thing, but I think it's a true bailout. It's a little unnerving to leave people in BF, but it's something you can do, and it saves. I think all of us who use ECMO definitely have had patients walk out of the hospital that otherwise would be dead in the cath lab. Saves a lot of paperwork too.
Yeah, and I think personally that if you're going to do hemodynamic support, you need to know the whole gamut.
Yeah.
And so what we would do in this case is we'd do what you did. We'd start with the Impella. If there's refractory VF and we can't do it, then at that point we would escalate to ECMO. And frequently our ECMO cases have venting with Impella anyway. So it's a conjoined thing that we do with us, perfusion surgery. And the only other thing I'd mention with abrupt closure is that we've seen a lot of trainees in our programs. They're biased one way or the other in their cognitive thinking, that one will think it's always thrombus, the other one will always think it's dissection, and somebody else will always think it's spasm. And as an interventionalist, it can be any of those three things. And really keep your eyes open and think of the differential in these cases, because I've seen cases of severe spasm where aspirate, 2B3A. And by the way, Impella plus Integralin is like, two eyes, or like, it can be a little bit of a problem. So just think of the differential at all times, and sometimes you can have more than one at the same time too.
Yeah, this is probably a combination of
Yeah,
both clot, and then we probably lifted a plaque or something.
This is what you were trying to learn with your original IVIS.
I wanted to look at the left main a little bit better and see if this was going to be a left main stent mainly. And we determined, we didn't have a chance to get to that. But after looking at the IVIS, I didn't think, it was really an osteal circ, and we left that for another day. Yes?
Any role for intracoronary lytics covers low dose?
Yeah, I guess, in the STEMI literature, we know that really didn't pan out. So I think that, we typically just aspirate. I don't know, interested to see what the panel thinks, but, when you do the STEMIs, often you just pass something down there and the clot just goes away. I'm not really sure how much aspiration is even helping. There's debate about whether aspiration even helps. But I would never do that. Like I say, we've sometimes given 2B3A. I'm not really sure why. I think we just do it. There's probably no data on that either.
Most of the data on intracoronary lytics show that you get intraplaque hemorrhage and you can make things worse. The other thing is because these people are supported, whether it's Impella, whether it's ECMO, they're often going to have bleeding issues. And obviously low dose is less, but I just don't know of any efficacy data for doing something, and it will activate your platelets and your coagulation cascade as well.
Yeah, if you have residual large burden of thrombus, don't forget large bore aspiration with guide catheter extensions. That's one of the things that I would go to before doing rear lytic thrombectomy in a situation like that.
Was that first ACT low, or?
We kind of injected heparin, or we gave a bolus of heparin as we sent it. I assumed it was. And so looking at that ACT after an additional bolus of heparin, I don't think it was too low. It was 315, so it went up even higher. So my suspicion is that maybe it was a little bit low. Thank you.
Awesome. Thanks so much.